Okay, well, it's a pleasure to be here today. I'm glad there's so many people here to hear about MIDRIC, and I'm going to focus on the kinds of questions we could answer with the MIDRIC data set. And we certainly hope a lot of people will want to give data so that we can have a robust data set that's highly representative of the population. Registries are really different animals than clinical trials. We basically, in a clinical trial, we recruit patients prospectively to test a treatment or a placebo. And you can answer big questions using clinical trials, but you can't, it's difficult to get real world data. It's not real world data. It's highly controlled, highly curated, and the patient population is highly selected. And as we know, often it's not extremely representative of the US population. There tends to be under enrollment of diverse populations for a variety of reasons. Registries, on the other hand, can recruit data from the real world where patients present to in clinical settings, and we can obtain images and more diverse data from the clinical encounter. In addition, we can, if genetic data is available, we can include that in the database, and it's more likely to be diverse if you work at it being diverse by recruiting sites that serve a more diverse population, which is what we're trying to do. And we're succeeding, I hope, with MIDRIC. So the other cool thing about registries that really is unique is that you can follow the same people over time, maybe even over years if the registry lasts that long. You can learn over time how they do it with their COVID in this particular case, which factors might contribute to their having a worse course of COVID, which factors might contribute to their doing better with COVID. You can collect data from a variety of settings, such as the emergency room or outpatient clinics or the intensive care unit. So you can really take a more broad view of a disease than you can with a clinical trial, where usually the patients are recruited in a specific clinical setting, and there's a limited timeline for evaluating them and keeping track of their outcomes. In addition, of course, the registry data can be used much more in real time for other purposes, education in particular. The use of AI is something that has been up until recently not democratized, not available to all researchers out there. What's nice about MIDRIC is it's a public archive that will allow anyone to download and use data, even people at perhaps institutions without a lot of resources. And so one can imagine reaching a variety of educational institutions, including perhaps even, young people at the level of high school or college who are just learning about computers and about AI. They're going to have access to this, as well as the most sophisticated data scientists at our most sophisticated institutions. And the kinds of questions you can ask are not just about imaging. They're really about imaging in conjunction with the clinical picture. And so, you can imagine a person who wants to use the images primarily to assess the efficacy of specific therapies. And so, this is really a very rich data source that can be used beyond imaging. We really, as Kurt mentioned, there's going to be a linkage to the N3C, which is the big clinical archive for the MIDRIC images. And so one hopes that the kinds of questions that scientists and data scientists in particular can address go beyond what radiologists and data, currently and medical physicists currently think about in terms of looking at images. The other big thing that Kurt has already mentioned, which I'll just re-emphasize, is public health surveillance and the importance of, recrudescence of the disease over time. As we know, we're going through a second sort of uptick. Let's hope it's not a spike of the unvaccinated right now. There may be differences with the new Delta variant that are being more evident to us as radiologists. The more data we have, the more we see the variety of presentations across institutions over time. So this is extremely important for public health to identify those early. In addition, we have, on behalf of MIDRC, the American College of Radiology has applied to CMS, which is the Center of Medicare and Medicaid Services, to allow for improved reimbursement if a site participates in MIDRC. We haven't yet heard back from CMS. We should hear sometime soon, we hope. But that's a motive for institutions to open their data systems to contribute cases to MIDRC. And we hope when we hear about that, there will be, of course, a press release, and we'll let you know if that happens, so that you can perhaps get the people who are not on the scientific side or the imaging side of things more motivated. They would, if they qualify for additional payments. Obviously there's a great scientific motive, but there are other motives as well that might drive your institution to help us with this important project. So I'll just tell you about a couple questions we're actually answering in the MIDRC projects. I know that Mike Tilkin is going to talk a little later about the same project, but I'm just going to talk about it briefly, and then he can tell you a little more about it. Essentially, we're going to look at predictors of poor outcomes using radiomics tools. This is a really cool project because it's multidisciplinary. It includes a medical physicist, Despina Kontos, or a data scientist, really, from University of Pennsylvania, and a pathologist who's also a data scientist from Stony Brook on Long Island, Joel Saltz. They're basically looking at the pathology of the pathologic test, the clinical testing systems. What do the clinical tests show in conjunction what the medical images show, to try to figure out which clinical images and what clinical findings correlate with worse or better outcome in COVID hospitalized patients. There are lots of questions about the long-term effects of MIDRC, including this brain fog that has been well documented by this point. I think the most prominent person who has reported this symptom who had COVID is one of our senators, Senator Tim Kaine from Virginia. He was quoted in the newspaper in that he was not feeling himself and his brain wasn't working as well. And I'm sure anybody who's had friends and family with COVID have heard about this, because it's not common, but it's also not rare. It's a complication that people are reporting with some frequency. And really, we don't understand it very well yet, but we have a ton of clinical images now of brains, both MRs and CTs, and we hope to put them in the MIDRC archive so that people can start exploring. Maybe there are some predictors of this long haul brain fog that people haven't yet identified. So here, this is some pictures that have to do with the neurologic manifestations of hospitalized patients with coronavirus in Wuhan. I don't believe this issue has been completely answered at this point, and we hope there's some really smart data scientists and algorithm developers who can help us put together and perhaps figure out a way to prevent this from happening. We can't prevent it if we don't know what to look for. So hopefully we will understand who's at risk better once this question is interrogated using the vast resources of the MIDRC archive. Here's some more pictures from children and adolescents who have multisystem inflammatory syndrome from COVID. That's another phenomenon that would be good to understand better. We know that children are at low risk for serious COVID, thank goodness, because it would be much more terrifying illness. It's pretty bad already, but if children were as affected as old people from this disease, it would be even more terrifying than it is. And but there are children who are dying from COVID, and there are children who are seriously ill from COVID, and it would be really great to get these images into the COVID archive so that we can start assessing what makes people sicker, what makes children sicker. So that's the end of my presentation, and I will stop sharing, and Mary Ellen will introduce the next speakers.